Okay, great. Thank you. So, good afternoon, everybody, and thank you for the invitation to participate in this meeting. Um, it's a great pleasure to be presenting to you today. It would have been even better if I was live with you. It's been a pleasure in the past to be in your country and enjoy all the hospitality and the wonderful environment. So, what I was asked to talk to you about today is non-clotting factor concentrate replacement options for the management of hemophilia. And what I thought I'll start with is recalling that the clinical observations made almost 60, 70 years ago, correlating with factor levels, led to the phenotypic classification of hemophilia into severe, moderate, and mild, and that correlated with clinical bleeding. So, in terms of treatment, almost simultaneously around the same time, at least in two centers in the world, in Malmo in Sweden and Utrecht in Netherlands, it became quite obvious that one way to manage hemophilia was to replace enough factors that would allow people to not be at zero, one and above if possible. And that is what led to the whole concept of prophylaxis. And this really became the gold standard for treatment right from the 1970s in most of the Western world. And the rest of the world has tried to catch up with this over the last several decades. However, episodic therapy still remained, till recently, part of the official narrative of treatment of hemophilia. So depending on where in the world you lived, people evolved different prophylaxis dosing regimen, and you could give lower doses more frequently, or you could give higher doses less frequently, and achieve prevention of bleeding to various extents, so that we have the standard dose at about 25 to 40 IU 2 to 3 times a week, to the intermediate dose of about 20 to 25 IU 2 or 3 times a week, to the lower dose of 10 to 15 IU 2 or 3 times a week. The bottom line was that in all these, you had to have multiple intravenous access, and you had to have peaks and troughs of these levels, so that when patients reached the trough, then of course they were prone for bleeding, and therefore they had to control their lifestyle significantly as to what they can do on which day at what time. And that is where this treatment gap was addressed about a decade ago by the extended half-life clotting factor concentrates. And what this slide shows you are the three technologies that have been used: the FC conjugation, albumin, or polyethylene glycol, to modify both factor 8 and factor 9 in a way that their half-life was extended, much more so for the factor 9, almost 4 to 5-fold, as opposed to factor 8, which was only about 1.6 to 1.8-fold. But what this did was to allow people to take these injections much less frequently on one side, and even more importantly, achieve trough levels which were now much higher than what was possible in the past. 5 to 10% for factor 9, and certainly much above 1%, 3%, or even higher, depending on how frequently you took the dose for factor 8. And again, we achieved more in terms of improving the life of these patients, less frequent injections, higher baselines, and therefore much more freedom of activity and living a normal life. But in spite of all this, there were certain challenges and limitations that clotting factor concentrates could not avoid. As I mentioned earlier, frequent venous access, and this is a major challenge, as you can imagine, in very young children, because treatment has to start very early in life. The peaks and troughs, and therefore they're prone for bleeding, breakthrough bleeding, and even in the best prophylaxis regimen, you have 1 to 5 bleeds per year. And then finally, after all this, you have almost 30% of patients developing what we call inhibitors or neutralizing antibodies, usually within the first 50 exposures or so. And so this is a real problem. In fact, I often say that in any other field of medicine, if a drug was known to cause serious adverse events in as high a percent of patients, then probably that drug would never get registration. But in this field, because we had nothing else, it had to. And then we have another problem. In spite of this success for the last 50, 60, 70 years, a large part of the world never got access to these products for many reasons, not the least of which was the challenges of producing these products, and therefore the quantum of these products available and the costs related to them. So for all these reasons, of course, we had need for producing other hemostasis products. And so the status on this was that prophylaxis is certainly the way to treat hemophilia, achieve hemostasis in a way that provides stable levels of whatever product we are using so that patients can live their life as normally as possible. And this was done traditionally with the standard half-life products and then the extended half-life. And now we have the non-factor hemostasis products. But what was very emphatically stated in the third edition of the Guidelines for Management of Hemophilia from the WFH was that the standard of care for all patients with severe hemophilia is regular replacement, prophylaxis with clotting factor concentrates or other hemostasis products to prevent bleeding started early in life. And more importantly, we should no longer consider episodic or on-demand replacement as a long-term treatment option. So moving on now to what we really want to discuss today, the alternative coagulation products or non-factor hemostasis agents. So here we need to just look at the hemostasis pathways and see where can we intervene. So the classical one was to prepare something which mimic factor VIII, and this came in several years ago now, but 5 years ago in the form of emicizumab, monoclonal antibody. We also could then look at balancing hemostasis, because what happens in a bleeding disorder is that you lack the procoagulants. Now that way you have Can you hear me? Are you hearing me? Are you hearing me?
Yeah, we do.
Can you hear me?
Dr. Alok, yes, we can hear you. You can go ahead.
Okay, I'm sorry. Okay, so what I'm saying is that we have several non-clotting factor concentrate products available, and the first of them was emicizumab, a bispecific monoclonal antibody, and then we have several in the pipeline. Again, monoclonal antibodies directed against the TFPI, or we have siRNA in development against antithrombin, and we have serpins also and against activated protein C. Essentially, what we're trying to do with all these products is to balance hemostasis. So as I was mentioning earlier, bleeding occurs when the procoagulants become less compared to the anticoagulants. So in hemophilia, for example, you have less factor VIII or IX. So if you somehow reduce the anticoagulants, then you can achieve a balance of hemostasis as well. So this is what has been achieved with some of the products. So let me start with the first non-factor product, which is emicizumab, which was made available outside of clinical trials from 2017-18. What this is a bispecific monoclonal antibody that recognizes epitopes on factor IXA and factor X, and then it brings them together in a way that releases factor Xa, very similar to what factor VIII would do. And what is shown here is that this drug, as a bispecific monoclonal antibody, can be administered subcutaneously once a week, once in 2 weeks, or even once a month. And you see the pharmacokinetics of this product, so you get very stable levels. And with that, of course, in 2017, in this pivotal trial, they were able to show that there was amazing reduction of bleeding in people with hemophilia A with inhibitors, much more than what could be achieved with bypassing agents in the past. Not just there was reduction in bleeding, but actually 60 to 70% of patients had zero bleeds, no bleeds at all, something which was much more difficult to achieve or almost unachievable with bypassing agents. The next year, the data on patients without inhibitors and hemophilia A came around, and this was of course more elaborate, but showed the same thing, that almost 60% of patients had no bleeding at all. and that they have much better hemostasis, allowing them much more activities. As you can see, there was major reduction in the bleeding from about 38 median to less than 2 median bleed, and the fact that these people were much more active with the level of hemostasis that they were achieving. So this was not only in the trials. Now there is extensive experience around the world. In fact, in some countries, more than 50% of patients are using products using emicizumab as opposed to clotting factor concentrates. And the result from real-world data experience is also very similar. 80 to 90% of patients in most centers are experiencing no bleeds at all. So this is a wonderful drug as long as you have access to it. But of course, if you do not have access, then you have to still rely on the clotting factors. The next product that I want to talk about is the siRNA against antithrombin. So here the concept is very simple. It's an RNAi-based post-transcription gene silencing. So you have an siRNA against antithrombin. It is conjugated with a GalNAc to allow its specificity to enter the hepatocyte as opposed to other cells. And once inside the cell, it goes and interferes with the translation of the antithrombin mRNA, reducing the levels of antithrombin. So in the phase 2 trial that was published some time ago, what they showed was that by using siRNA, you could increase thrombin generation in patients with hemophilia A or B. And what you see here in the red dots are the normal thrombin generation levels. And by the time you reduce the antithrombin to below about 25-30%, you can see that the red and black dots are tending to match with the normal levels. So you can actually almost normalize thrombin generation in these patients, and that these are dose dependent, and based on this data, they could design further clinical studies. And so what was presented at the ASH meeting a few weeks ago was the phase 3 data, first from the inhibitor patients, and what they showed you was that the median bleed came down to 0 from about 13, and even in the non-inhibitor patients, again from about 15 to 20 bleeds, it came down to 0 median. So this is again very remarkable reduction in bleeding with the use of this siRNA fitusiran against antithrombin. So this data should soon be presented, I hope, for the regulators to review. And this is again a product that we are looking forward to becoming available to patients. The remarkable thing here is that it is something that works for hemophilia A and B, and it works with patients with or without inhibitors. So it is the first of its kind, a one-stop shop for treatment of hemophilia, a kind of product that had never been available before. The last product that I want to talk about in terms of non-factor products for hemostasis is concizumab. So this is, one of the prototypes for an antibody against tissue factor pathway inhibitor. And this is the proof of concept data, where by spiking this into plasma from patients with hemophilia A or B with inhibitors, they could show that there was increase in thrombin generation or the endogenous thrombin potential, in the ETP. And based on this, they actually went ahead and did a clinical trial. And this clinical phase 2 trial, what it showed again was that there was remarkable reduction in bleeding. Though here we have some issues. We have still the median ABR being more than 3, which is a matter of some concern, and also several patients had thrombotic episodes. Now, we must understand that these are major modifications in the way we have tried to achieve hemostasis, and so there will be a learning curve with all these products, and we need to find that sweet spot where you get enough hemostasis without thrombosis. So phase 3 trials are going on with concizumab. There are at least 3 other products from different sponsors with TFPI antibodies, and we hope that those trials will also proceed so that more options become available for people with hemophilia. Now, as I said earlier, we're trying to balance hemostasis and normalize thrombin generation. And this is some data that was published a few weeks ago that show what happens to thrombin generation. You can see that even bypass agents increase thrombin generation, but these are with peaks. Soon they go into troughs, and this whole situation that you see on the left will change. But unlike that, with emicizumab, with concizumab and fitusiran, what you have are sustained levels, and therefore you have sustained thrombin generation potential in the plasma. And so the kind of hemostasis that we are achieving with these non-clotting factor concentrates is very different and much more sustained, allowing patients much more freedom of activity and leading a much more normal life. Now, this talk will be incomplete if I don't mention gene therapy in it at all. So, in terms of factor replacement, what could be better than producing your own factor, be it with an artificial gene that has somehow been put into the body? So that is what this cartoon shows, that there are two ways to do this. One is to have the transgene packaged into a vector that is then injected into the body through an appropriate route to reach an appropriate cell. In this case, most of the studies being done at the moment, as you know, are with the AAV vector, the adeno-associated virus vector targeted at the liver. But another approach could be to take stem cells from the body, transduce a therapeutic gene into it, and then put that as an autologous transplant, currently being done for immune deficiency disorders and the major hemoglobin disorders. But this is something that one could look at for hemophilia as well. So the first success, as we know, was reported almost 10 years ago in 2011 by Amit Nathwani and colleagues, and followed up in 2014. Now, that was much lower levels of about 3 to 5%, but that led the foundations for the current trials. And the most advanced one in factor 9 is that from Spark Therapeutics, the data from which was published now about 4 years ago. This has matured to a point where we should expect registration soon. What you can see is that using the Padua variant, they are able to have sustained factor levels in the mild hemophilia range, 15 to 50% in that range. And this should really be something that will change the lives of these people. Not clotting factor concentrate, but being infused, but your own. Now, very recently, we had two publications giving updates of the factor VIII trials. One from BioMarine showed here, one from Spark Therapeutics shown here, where you see that there are challenges. 4 different doses have been tried. You see them in 4 different colors, the 4 different doses of the vectors. And what we are finding is that there is a major reduction after the first 6 to 12 months in these patients. So we have patients going up to normal, 100%, or even supranormal, more than 200%. But after the first 6 to 12 months, there's a major reduction in almost all the factor VIII trials. And what is shown here is that at 3 to 4 years, these patients have somewhere between 5 to 20% of factor activity. And that is something that is still remarkable. But then, we got used to the idea that maybe we can get normal. And then when you land up with 5 to 20%, you kind of wonder how long this will last. And is this truly better than some of the other options that I described earlier? Very similar data from BioMarine, where initially they had very high factor levels. In fact, some again going more than 200% in the first year, particularly with the high dose shown on the left. But then as we went through the second, third, fourth, and the fifth year with a higher dose, you can see that the factor levels have now dropped somewhere in the 5 to 25, 30% range for most patients. Again, something quite remarkable in terms of giving relief of bleeding, but not in the range that was expected some time ago. So that is where we stand. There are multiple clinical trials going on. So this is good. The problem is that all indications are that when these products become available, they will cost somewhere between $2 to $3 million. So how many people in the world can afford that, even among the Western countries, remains to be seen. More importantly, with AAV-based trials, we really can't expect to treat very young children below 10 to 12 years of age till their liver matures in size. So that is a major problem. And AAV naturally occurring antibodies, anti-AAV antibodies, occur in 30 to 70, 80% of people around the world. So if you belong to a part where there is a high prevalence of anti-AAV antibodies, then this again may be a challenge. So for all these reasons, actually, we have also been looking at developing gene therapy. And this just shows you data that was published now about a year and a half ago, using a novel AAV3, capsid with a novel transgene prepared in collaboration with our collaborators at the Emory University and the University of Florida. And what this shows you is data from 2 mouse models. One in the hemophilia B, where the transgene has been packaged in AAV8 because AAV3 does not infect mouse tissue. And what you see on the left is first the comparison between this transgene and the one used in the Amit Nathwani trial, giving very similar factor 9 activity. And then you see on the right that there is a dose dependence of the expression. And then you see this transgene packaged in AAV3 and tested in the TK nog mouse with a humanized liver with 30 to 70% human hepatocytes. And this shows you that there is again an expression which is dose dependent. So now we are in the process of having this vector produced. There was a major challenge. As you know, this is a bottleneck for the entire field in the world. And once we have a GMP-like vector, this will move into a clinical trial. But as I said before, we have concerns that we will not be able to treat young children. And so by the time they are 10 or 12 years of age, unless they have received good prophylaxis, they may have all the complications of hemophilia. And so we have looked at other options, and this is the one that we have developed in collaboration with Dr. Trent Spencer at the Emory University, where we have a unique transgene that will be transduced using a lentiviral vector into the hematopoietic stem cells with a specific monocytic restricted promoter. And this was tested again in 2 mouse models, one in the hemophilic mouse with the hemophilic hematopoietic stem cells showing very high expression of factor 8. And then in the nog mouse, the NSG mouse, with the human hematopoietic stem cells with this transgene, which is the data shown on the right.